So, hi everyone. My name is Chris Calkins, and I come to you today from the not so sunny shores of Forest Lake, Minnesota. We'll see if any jet skis or anything grace us with their presence as we have our coffee chat. And I do have my coffee just with my tagline on it, just to make sure it's legally considered coffee chat. But anyway, I'm joined today with Tamara, and I'm going to let her introduce herself and who she is and her background. And we're just going to have we'll see where this conversation goes.
Thanks, Chris. Thanks for having me. My name is Tamara Beekler. I am a hospitalist and also have a master's in healthcare administration. So my practice is half clinical and half administrative, primarily in hospital administrative type of work. So a hospitalist really is an internist who specializes in the care of hospitalized adults. So adult patients who are in the hospital, but internal medicine is my background. And my specialty really within hospital medicine and also administrative work is in the discharge planning and care transition space.
And I would add that I think I'm right in saying you kind of got your start in EMS, didn't you? Emergency medical services?
I did. So when I was, way back when I was introduced to emergency medicine by you, Chris, in my first EMT basic course at Century Community College. That was when I was in undergraduate. So I was an undergraduate at Hamline University, and a friend and I enrolled in one of your courses thinking that it would be fun and exciting work. And then actually worked for a while as a vehicle service technician for one of the local ambulance services, and took an intermediate EMS course from Chris as well. And then at some point in there, went to medical school.
Because she is bored and has
Yeah.
nothing better to do, and somehow managed to raise a family and did other things on the side anyway.
Yeah.
Like everybody in EMS, I guess, who came from EMS, we have a lot of things going on in our lives. So you talked about internal medicine and what a hospitalist does. I'm interested in how you interact with community paramedics, or how you came about to work with them, that kind of a thing.
Maybe I'll start with just expanding a little bit more on my role in hospital medicine. So being a hospitalist is really kind of like shift work. You never know what your day is going to look like. I suppose I carried that over from the early EMS training. I like that unpredictable nature of work and taking care of acutely ill patients. The setting is obviously different in the hospital, but that's sort of the nature of the work. Shift work, unpredictable. You never know what's going to come to your service, or what will be transpiring with a patient at the beginning of any given day. I do work at a tertiary referral center, a large institution, and so we deal with complex patients who are transferring sometimes from nationally or even internationally, and have, are there for second or third or fourth opinions, and present with complex, sometimes it's not clear what the diagnosis is. So it's a diagnostic pursuit or advanced treatment options, for example. And I really, early in my work in hospital medicine, I realized I was interested in the discharge planning and care transition space. Somewhere in there, I went while I was working and got my master's in healthcare administration as part of the executive program at the University of Minnesota. So did that alongside other professionals who were also already working in their careers, but wanting that advanced training. And that's sort of what led me down that path of the discharge expertise and transition planning. I think it's been almost 5 years at my institution, the development of the community paramedic program. I've come just recently in the last year or so to be working more closely with the medical director for the CP program, and thinking about, she and her team are always thinking about ways to expand their program and services to offer. And so we've done some collaboration just in that space of thinking about, are there specific diagnoses that hospitalized patients have that we can leverage the expertise and, treatment of the community paramedics. We've talked about diagnosis specific targeting versus patient populations, just different ways to craft the program collaboratively to really optimize resources. I guess I would say one of the ways we're exploring that now is in specifically discharge planning and trying to get patients out of the hospital sooner. And are there populations of patients that can benefit from CPs in the home or community? As you know, probably better than I, it doesn't always have to be a home environment. Get them back to a less restrictive environment sooner rather than staying in the hospital.
And you talked about patients from all over the place and all over the world. Are there cultures you work with in your area more than others? I happen to be working on the cultural competency lesson, so this is just on my mind, but are there populations that you work a lot with that are unique in certain respects, or anything come to mind?
It's a great question. I think nothing that's been targeted. I would say that some of the target populations are more about socioeconomic diversity rather than specific cultural groups per se. So for example, our community paramedics have a great service collaboratively with a homeless services agency. The Landing is the name of the group to provide care for people who are homeless in the community-based patients who are homeless, as well as a mobile COVID clinic for, again, for homeless patients who have COVID and would benefit from services. So different touch points for that. I think the other aspect that's really interesting in the community is the engagement and collaborative that the team does with the local police and other emergency responders for mental health crises, for example, to be able to provide support again and sometimes avoid ED visits altogether with the support from the community paramedics.
Obviously, you and I know each other, and and I know that you share the same feeling that mental health is a passion for both of us. We're both very interested in that, and in particular, we're concerned with suicide and preventing it. And maybe this is a little bit of a sidetrack, but what is your role with that? And do you know of any programs specific to that that CPs work on? Of course, that's my pet project, so I'm going to ask the question.
Of course, I appreciate the question. You know, Chris, I think it's a real opportunity area in my area as well as other locations, I would imagine. I think we're starting to put feelers out and do things like these response teams or crisis response teams. I think we're still learning about what makes it effective, what support can be provided that's more meeting the needs of the particular individual in the situation, less as a police type of response or law enforcement type of response, and more about what is the situation with this person and how can we help them in their own environment to try to diffuse and de-escalate and get to what the real situation is, as opposed to thinking about it like a more of a law enforcement issue. I think traditionally that is probably the type of response that happens in these type of crises, because that's what we have as communities in place to respond for emergencies. And so I don't know that I have experienced or have the answers certainly, or that there's an established program that's highly effective, but I think it's exciting to see the possibility of community paramedics assisting in that space for that reason.
Okay, so of course, like everybody asks us in EMS, what's an interesting call you've been on, or whatever. What is an interesting patient to you, and what would a complex patient to you be, or is there a favorite subject or topic or something that really interests you in your work?
In my work in general, Chris, or related to the community paramedics?
I think a little of both, maybe either or,
Mm-hmm.
just whichever you prefer.
Well, I mean, personally, I really enjoy, I suppose a lot of internists may answer the same way. I think what drew me to internal medicine in general is diagnostic pursuit and the puzzle and complex pattern of symptoms and physical findings and objective and subjective findings, and how do you put the pieces together and really have an impact to be able to provide a diagnosis and then ideally treatment options for people. So that's my favorite type of case. And I suppose that's why I find myself in an academic tertiary referral center, because I love those cases. I think I probably most of us who are in healthcare, in any aspect of health, it's the reward is in being able to help people and see that you had an impact. And I think it's for me, it's in the complex situations when you can really help somebody navigate. It's not necessarily just about getting them a diagnosis, but how do you help them navigate how they handle that, how they cope with that, what they do with the information, how they process their options, to really be a support for that and know what resources are available, and how to use my expertise as a hospitalist to explain in a meaningful way that they feel well informed to make the choices that are right for them as a patient and for their family. That's probably why I'm also drawn to the transition space, is thinking about the continuum of care. And as much as I like the acuity and the fast-paced nature of the hospital work, that's my connection to the longitudinal care, is to be able to think about what happens to our patients after they go back home to their home environments.
Thank you. How do you interact with CPs then, or how would your field interact with them? I recognize that you're administrative and educational. There's lots of pieces of you, but how can a CP supplement your field or be helpful or beneficial? What do you see that role as, or maybe specific actions or diagnostics, things they can help you accomplish, or et cetera?
Well, I honestly, I think the opportunities are endless, and currently involved in a large project that has a lot of different stakeholders, where we were feeling out protocols and management for heart failure patients to discharge sooner from the hospital, or maybe even not make their way into the hospital, knowing that the management of their heart failure required IV diuresis, but could be safely managed in the home environment in terms of the monitoring. So a relatively smallish cohort of patients. And I think to be able to develop the processes there and the monitoring and the what do we do when this happens or the next thing happens and how do we respond was incredibly rewarding to see the outputs of that. Again, it was a complex system, collaborative, with lots of different people involved in figuring that out. But I think it was pretty remarkable to see in this particular program, the community paramedics had 1 to 2 touch points a day with the patients of no more than an hour-ish each. So high-ish frequency, really, to go to somebody's home for over a period of days for 1 or 2 times a day, and yet to be able to have the impact at that time. I think what's really exciting is that patient in the hospital, I could prescribe them the same Lasix IV and bolus it and monitor for output, and maybe talk to them about what Lasix is and provide some education on heart failure management. But the CP aspect is not just doing that at home, which in and of itself is pretty amazing. It's that they're able to do the assessments of the home, some of these psychosocial assessments, and just look in the cabinets and see, well, here, I see the problem. Your sodium intake is through the roof. And when I maybe would talk to that patient in the hospital, they may hear that, they may accept that education, but not really know what it means or how to translate that into reality. So it's all rooted in a good collaborative back and forth communication to have a plan, but then be able to, for the community paramedics to be able, I really value that they're there and can have that insight, and then pivot their education to maybe emphasize something more specific that's just in time needed for that patient based on their observations. So education and the assessment of the home situation is critical, and something we can't even do if we had hospitalized that patient. We don't have that access in that way to that home situation. I think, they've also been critical for home safety situations. So maybe a patient who is in the clinic or even the hospital, and you're helping them mobilize and taking a look at their functional situation. A physical or occupational therapist may work with them and make some determinations. And I think those are great things in the hospital. We rely on those services and assessments all the time. But again, seeing somebody in their home and what their setup is, and are they safe, or is it clear that turns out the CP arrives and there's some real concern. Sometimes we can address those. Sometimes it's enough to say, hey, we're able to problem solve this, and you actually need some additional help, and we've sent patients to be able to go to a skilled nursing facility, for example, because if we just weren't able to manage the problem in their home safely. Right there, that's a real intangible. There are a lot of things we can measure with the CP's impact, and they're pretty impressive in terms of dollars saved and all sorts of important metrics. But some of those things that are caught that maybe would have led to a catastrophic injury for that patient, they had a terrible fall that had all sorts of downstream repercussions. Those are saves that are hard to measure, but equally or possibly more important. So I don't know, those are a couple examples of sort of a diagnosis specific approach, but there's just so many others.
So a community paramedic, if I'm understanding what you're saying, if I were the community paramedic going into somebody's home who had congestive heart failure, I'd monitor where are they taking their medications, perhaps look for interactions and things that other people or over the counter remedies that they're taking to see if there's anything there that is of concern. You mentioned the high sodium. That was exactly what I was thinking as you first said. I enter the house and look around. It's like, yeah, all the bags of potato chips. Oh, I hope nobody comes and looks at my house.
Right.
Practice what I say, not what I do, right? I would imagine your regular vital signs and listening to lung sounds, and do they have peripheral edema and pitting edema? I would imagine in some cases you might want an EKG. I would guess sometimes you might need lab work drawn.
Yep. Yeah, to be able to do labs and vitals and administer medications and things that, traditionally patients in their homes administer oral medications. I think very traditionally these episodes of care have been somewhat artificially, the lines are drawn, and we're moving into a next phase where we think about it differently, because it was patients are outpatient or they're inpatient or they're post-acute care. But what about gray areas? What about bubble patients who don't really need the full intensive care of an acute care hospital, can manage at home, but not with existing outpatient resources? Enter the community paramedics who are able to bring some of that into the home, I think, and more. That assessment piece, I don't know, I just can't emphasize that. It's really the eyes and ears extension into the home. And I think too, you make a good point about medications. I was probably remiss in not mentioning that. There's so much to learn about patients and their use of medications. Do they have their pill box filled properly? Does it look like they're actually taking their meds? Do you come to find out that, yep, here's my med list, but I don't take half of that because I don't like it, or whatever the reasons are, and to be able to problem solve those, that's another high impact.
Or they ration them. I've seen people do that. Yep. 911 calls too, where, well, they're expensive, so I'm only taking one pill a day instead of two, or half, or I'll skip a day. And then so people do some interesting things to save money, and that gets that socioeconomic piece that you were talking about, and those very real stressors for sure. You talked about LASIKs. Would it be conceivable that a community paramedic would give LASIKs intravenously at a house, or are you referring to oral medications? What do you?
Yeah, our community paramedics are giving IV medications, drawing labs, administering IV medications. Of course, again, you know better than I the scope of a paramedic in general. I think it certainly expands for our community paramedics in terms of what they're administering and under what circumstance. Calls and oversight of the medical director for the ambulance service that the community paramedics are a part of, but absolutely IV medications and IVs in general, hydration, things like that.
How about vaccinations? Anything like that? Have you get involved in that, or has that been something?
Yep. Yep, certainly vaccinations. Yep. I suppose probably you're getting a little bit of a skewed picture of my vantage point because I'm deal mostly in post-acute care and patients that are hospitalized or were about to be hospitalized. But I know just from working with a community paramedic group that they do a large part of their practice is in more of a basic primary care, sort of preventive care type of population. We had in one of the neighboring states, our community paramedic program was doing some work really just in high utilizers of healthcare resources. So patients that weren't necessarily coming out of the hospital or needing to be hospitalized, but they were patients that were identified because they were accessing lots of healthcare. So ED visits, maybe clinic visits too, maybe frequent hospitalizations. So a variety of different access points. And so they were identified as a possible population where the community paramedics could have an impact. And so it wasn't necessarily they were going in to target one disease, like we have a heart failure exacerbation, we need to do LASIX, we need to monitor labs, and not that, but really more of a preventative approach, basic education on the chronic diseases that they were dealing with that probably were the nidus for accessing the healthcare, the medication management, the environment assessment, these sorts of things. And it was highly effective in helping reduce the hospitalizations, ED visits, some of the things that have other impacts. So, and most of our patients, they want to be successful in their own home. They don't want to have to go to the hospital and go to the emergency department. So high satisfaction just in terms of self-activation and being able to care for oneself with the resources you have and not needing to go out and seek extra assistance. So I think that's an example of the program really being effective more in that primary care preventive setting as well.
Yeah, absolutely. And I like that you call, and of course, you're very professional, so you would call people that utilize the system a lot high utilizers, and that's the proper term. I won't go into the other derogatory things that people say, but I'm guessing a lot of those people who might be paramedics know what's said. And I think that diminishes I think that's evidence of compassion fatigue, actually, that it kind of diminishes people's valid healthcare concerns and things like that. They obviously have something going on, it might be psychosocial or
Yep.
those kinds of things. But I appreciate the high utilizer term, and I would encourage people watching this to please refrain from those other terms and to use high utilizer. I think that's more appropriate, and it's very succinct and explains it well.
Well, and I think just any situation when you approach to seek understanding and with compassion, and the majority of patients in general, but even that population specifically, there's something causing that. It's not just people enjoy to be high utilizers of healthcare. There's something going on. And so I think as healthcare professionals, part of our duty should be to seek to understand and to try to figure out what we can do to help mitigate those situations and encourage the individual to be self-sufficient and self-activate. And I think, and I actually, even more specifically, this CP program with this group of cohort of patients that I'm referencing is a perfect example of it's effective. It's effective because there are things that we can do rather than just assume that, well, that's just the way that population will be. It worked because there were problems to solve, and solving those problems had an important impact.
Right. I think maybe Abraham Maslow was onto something, hierarchy of needs and that kind of thing. So I would just throw out to the audience that maybe there's probably something wrong in that triangle of needs. They're not feeling safe or secure, or can't get food, or they don't have shelter, or that kind of a thing. They're not going to all be self-actualization and be able to collect art or something, but
Yep. Yep.
Yeah, I think people should think about that when they go to places. They're calling for a reason. And to me, I don't know, I notice, I have this theory, I'm curious what your reaction would be, but I think a lot of calls that I go on are because people are lonely, actually. That they want other company, or they want to be with somebody, or it's a byproduct of that. But I think, the United Kingdom has taken this so seriously, they actually have a Minister of Home this as a real cabinet position.
Yeah, that's
Something, is it out there ways?
no, that's interesting, Chris. I mean, there are probably so many reasons that unless you're in those positions, it's hard to understand. We certainly see that in the hospital, in our geriatric population in particular, depending on their home situation. I think the homeless population is another group where if we're able to meet them where they're at in the community, we can help problem solve some of those things. But hospitalized population, it's not uncommon to see patients who are seeking the food and shelter, and when it's cold out and it's winter and we're in the upper Midwest, we see higher percentage of that population in the hospital and for longer periods because of different reasons, but they probably go back to that food scarcity and shelter. So absolutely.
I think it's a bigger problem even in the US than we think it is. We're often shielded by our own experiences or whatever, and don't live in that world. But yeah, I'd encourage community paramedics to be looking for those kinds of things and be sensitive to it or know when it's going on. So switching topics a little bit here because, well, I'm a paramedic. That's what I do. I just chase after squirrels and move from shiny object to shiny object. But back to chronic disease management in the home, do you have like a list of things like you wish your patients would do that, like the common sins or whatever that they have that you wish they would do to take better care of themselves or pay more attention to or not let slip? I mean, we all let things slip and we're all guilty of not paying as much attention to our health as we should. Floss your teeth every day, all the ones you want to keep anyway. Stuff like that. But what are your like your bugs that you're like, I wish people would just do this more, that maybe we should as community paramedics be looking out for?
I mean, probably the biggest thing, number one, would be physical activity and how to make it easy and accessible for people. In the hospital, we approach from the perspective of mobility and functional status and physical or occupational therapy to try to increase strength. And we have all sorts of fancy things and tools and exercises. But I think I often wonder how realistic that feels for patients in their home environments. Can they figure out how to be active within the constraints of their situation, how to use some of the things they learn, how to modify it for their situation? I suspect we as healthcare professionals could do a much better job making these things accessible and realistic for patients. It's really easy, like for me as a physician, to say, well, I really recommend you exercise 30 minutes a day or just get out and take a walk. But there's so many different things that could go into that. Do they have a safe place to walk? Can they walk? Do they, or do they have limitations with that sort of thing? And so I think that gets back to where that's a potential area for that chronic disease management and just preventive health that community paramedics could really be an asset because of their view into the home situation. What is the home like? Are there stairs? What things that are existing could be leveraged to improve activity? That would be my number one. I think as a hospitalist, we see the way that chronic disease is left unmanaged, over years. We see the worst cases of those sorts of things, poorly managed diabetes and the amputations and all the things that come from that. And so much of that goes back to, if we could help people understand how to exercise and how to eat better and avoid things like tobacco and excessive alcohol intake. Those are the bread and butter fundamentals. And I think it's a real opportunity, because what better way? It's easy to preach that, but to help people understand in reality how to do those things, is a whole nother story. So it'd be interesting to me if and I don't think that would be easy necessarily for community paramedics, because you'd be in the same, you walk in and here's the cards we have in this home situation, what to do. I think we'd need to have conversations about what are ways to pivot, to use existing things to make an exercise plan, or sit on the edge of the couch and do some squats just to get moving, or this sort of thing, to kind of have some of these things in your back pocket. But I think that would be really fundamental and critical.
I'm reminded of some trainer told me one time, and he said the best kind of exercise is the kind you do. So sometimes it's just something small, but you can have these grandiose plans, but if you don't
Mhm.
follow through on it, you are better off just taking that 10-minute walk every day, or whatever it is. I also have to smile because as you're talking about this, I'm thinking about my colleagues in EMS, the ones who know where every Burger King, McDonald's, and fast 20 square miles, the ones who might smoke, chew tobacco, probably self-medicate some things too much with fun after work in an alcohol sense. Are we in a good position? I guess is again back to that what I say, not what I do thing. But I think it's incumbent on us to try to model some of that stuff the best that we can. Nobody's perfect. I certainly.
Yeah, I had a taco for lunch, Chris. But no, I the other I think important point of that is that to teach people it's not about this or that, about the moderation and about to allow some it's not about every choice being the right choice, the best perfect choice, but a certain threshold of the choices throughout the day to meet that mark. You may one day just feel like you just need to sit and read a book and not be as active, but then hopefully the next day you can activate and make a couple different choices to even walk more back and forth in your own home or something. So I think that's the other point where we need to meet people where they're at, as it regardless of community paramedic, physician, and anyone in healthcare, and not preach to people, particularly to your point, none of us are doing these things 100% of the time, in our own lives. So to make it unrealistic for people just makes it that less likely they'll even do anything, right? But if you get to make 10 choices today about diet or exercise, try to make at least 2 that you think go in the great category.
You talked a little bit about reading, and I love to read. I like to do things that are mentally stimulating sometimes. And again, just another little field trip here. But I hear a lot of talk about keeping your mind active,
Mhm.
especially amongst the geriatric population, and how that promotes longevity and mental health, and which is attached to physical health. And do you have any thoughts on that, or is that just really out there beyond your discipline?
No, I think that's 100% accurate. I recommend that to patients all the time to keep the mind active. And really, I think you said it well already, but the one thing I might add to that list is just as we age and keeping the mind nimble can help, and active reading and puzzles and just any sort of engagement where you're using your brain like that can help prevent other things, memory loss and, dementia progression and things of that nature. So there are so many reasons to do that. Yeah, I think routines, I mean, even in patients with advanced dementia, we like to use activity pads and things to keep their hands moving. Of course, in more advanced dementia, you're not doing something like reading or puzzles of that nature that we were probably referring to earlier, but even in those stages to have activities is really important.
It seems like some things are just like,
Mhm.
muscle memory isn't the right word, but
Yeah, some of those long-term things that were learned decades and decades ago are retained in certain types of dementia. Certainly, it's more that short term. And of course, as it would progress, I mean, in the classic, more of an Alzheimer's dementia type of picture, it would eventually, most patients would progress to having those things impacted as well. But certainly in the earlier stages, many of those things are retained, which is always fascinating.
should we be vigilant for anything there in that environment to look out for our patients? Obviously, we need to be advocates for their care and attentiveness and things like that. But are there things that you see that are a concern, or things that just need to happen in your estimation to make care better?
I think the most critical issue facing our skilled nursing facility partners, and I would probably say any post-acute care skilled services right now in the region and even beyond the region, is the staffing, as you mentioned. So we have far more beds and physical spaces, whether it's a SNF or a TCU or acute or long-term rehab, whatever the setting. There are many different acronyms to describe these type types of places that all have different reasons for patients residing there, but we have far more physical spaces and we have staff that are able to care for patients or staff those beds is sometimes the term that will be used. And that extends even into home health care. Our goal in discharge planning for hospitalized patients is always to pursue the least restrictive environment. So if we can get patients back home and be able to do that safely by layering on different levels of support services, that that's the ultimate goal. Home health care sometimes can add on enough of a skilled benefit if patients need a few things, maybe to help set up meds, for example, or in-home therapy periodically, but they're otherwise able to manage the majority of the day on their own, all the way to the level of full nursing care in a skilled nursing facility. There's different types of skilled nursing facility beds, even if we exclude and other types of facilities. There are considered acute rehab beds where the prognosis for those patients is to recover and be able to return to their prior living situation. And then there are long-term beds that are licensed and planned for long-term residents. So that would be patients who are not expected to be able to return back home to the prior living situation. Most often from the hospital, we're looking at acute beds, and with maybe a short-term rehab stay, patients will be able to recover enough to discharge back to home, for example, or back to an assisted living environment. I think from the perspective of what types of things, I personally, I work in partnership and very collaboratively with our post-acute care providers in regionally. And I think it's all about communication and sharing information and making sure that there's a good understanding of what the situation is. So I would think from my vantage point, one thing that is always helpful for me, let's maybe use an example, this would be less about community paramedics and just a paramedic in general. I can be on the receiving end fairly frequently of a patient that maybe was brought from a skilled nursing facility to the emergency department by a paramedic, and then to from the emergency department to my care on a hospital service. By the time I receive that patient, it may be 12 hours later, it may be 5 handoffs later. But I will say I routinely on every one of those patients, I look back for the paramedic's handwritten report, and I'm looking for observations and things that, they've noticed in the field that might be relevant. Sometimes the EMS who've responded to whatever that situation is, again, most commonly in this sort of situation would be some sort of emergent situation, a patient who is found down or fallen or, whatever the things. They've had the first and only contact with whoever was the observer. Maybe there was a witness, maybe somebody saw something that's helpful, or maybe there was a family member there that you made a note about that I didn't have access to at 2 a.m. So I think any of those observations are helpful, quite frankly. But I've looked for things like, how was the patient positioned? Do we have any idea how long they were down? Any sense that they hit their head, or how things transpired? That scene assessment is really critical, even down the line, 5 handoffs in.
That's encouraging to hear as a paramedic, because I think one of the things we are guilty of griping about quite a bit is nobody reads our report anyway. So that's nice to know that somebody 5 handoffs down the line could find that valuable too. And that goes to the importance of documentation then.
Oh, Chris, I think that's worth emphasizing. I would say I don't think I'm unique in that. I know all my colleagues look for that information in the stack of things you get from the emergency department, but because most of the other things after that are summarized or available, you scan the labs quick, or you look at the final summary note of various observations from the ED, but that on the scene note is the thing that isn't, otherwise captured or reproduced.
Well, I'm happy that you're reading them. That's great. We always worry they fall into the black hole, right?
Well, they probably sometimes do. I hope not. I hope they always make their way up.
How about CP reports? I assume you're reviewing those then as well. And are there things that you're looking for? Probably a lot of the same things as in a 911 report, I would imagine.
Well, that's actually an interesting point. I may not, I might have to defer that I'm not an expert to answer that very directly. I think again, it's probably because of my vantage point. I probably am more of the sender of patients and the they connect back with maybe at that point their primary care provider in the community. So I'm not necessarily receiving that information or managing that care from that point, if that makes sense.
But presumably somebody's reviewing those reports.
Yeah, I mean, I absolutely.
Okay. The power of documentation. I, well, we're coming on quite a while chatting here, and I want to be respectful of your time. I just really appreciate that you're meeting with me like this, and I hope everybody watching this is too. I'm sure they are. I've learned a lot just having a chat with you. Sadly, I ran out of coffee, but
Yeah, no, this was fun, Chris. I always enjoy chatting with you.
I enjoyed chatting with you too. Is there anything you'd like that I didn't ask, or anything that you want to convey to the people watching this video that you feel is important that they know?
I have a ton of respect for community paramedics in general. I think since inception, I think what in Minnesota, Chris, you would know this, has it been 9-10 years since really the program has been in process in Minnesota. I would think that job opportunities and the career development opportunities related to that space are endless, and I think those of us in the hospital practice side of things really appreciate, value that perspective and that work. And I personally, with our local community paramedic group, it's one of my most exciting projects to be able to be a part of, and I'm really looking forward to all the next iterations. I think it's such a young field, really, relatively, that there's so many opportunities that are out there for expansion and ideas, and how to take it to the next level and have a bigger impact. And do we move on from things like disease specific and problem specific approach and primary care approach? What other ways can the program be helpful? So I think it's really an exciting time for the field, and lots of research and I think work to be done studying the outcomes and the impact.
And they're lucky to have you. It's always nice to have doctors that are favorable to EMS and appreciate what we do. So thank you for that. That's nice to have. I guess with that, I almost feel obligated to ring the bell behind me.
Yeah, let's do that, Chris. I want to hear it.
That's a wrap.